Thank you, Blandine. So we are going to move to our working lunch. We have a new agenda this year where we have a case theater that is sponsored by Philips. So we thank Philips very much for that. Drs. Nathan Kong and Peter Zimmerbaum will present a fascinating case that is apropos of what we just discussed: pseudofontan physiology from venous lead obstruction. And we will get to that in a couple of minutes after a word from our sponsors.
Tim is a joy to be around. He is a wonderful partner, and he always stays positive no matter what's happening.
I've always just been a really active person. I like to fly fish, I like to swim, mountain bike. Me and friends and family have hiked 14ers in Colorado. One of my goals was always to do a triathlon, and so signed up for a couple of them. But what I started noticing in my long workouts, some real shortness of breath and some real trouble being able to get my heart rate back down and recover. And so I went to the doctor, talked to her about it.
She recommended that we go see a cardiologist and see if this could be contributing to the issue with his running and getting out of breath.
Tim was diagnosed with hypertrophic cardiomyopathy, a thickening of the heart muscle that's abnormal, and it can impact the heart function over time, but it carries with it some risk for cardiac arrest, and it's a genetic problem.
We have 3 children. Jackson is 18, Nolan is 15, and Marielle is 13. When we found out that it was a genetic condition, I was very nervous because I knew this could be passed on to my children. We found out that our oldest does also have the condition. It's been a lot to go through, but there is some comfort knowing that we have this great technology that can help them.
The concept of Aurora EV-ICD is astounding. It's a device that can be implanted and allow a person to live a normal life. But at the moment of their cardiac arrest, it can intervene and save their life. It's completely outside the vasculature. It offers protection from cardiac arrest without the problems of leads inside the heart itself. So for a young athlete to not have wires inside their heart is a big deal because they're gonna live a long time with this device.
When Dr. Zacabe talked to us about the Aurora EV-ICD, I could tell that he was excited about it and about its benefits and the technology in it. That was definitely something that piqued my interest.
After a full conversation of all of those considerations, we both came to the conclusion that the Aurora EV-ICD was the proper device to offer in his case.
I received the Aurora EV-ICD device in April of 2024. After the procedure, I only spent one night in a hospital and got to go home the next day, which was great. I was out of work for just a few weeks, and I would say I was back to most of my regular activities within a month, and within probably 2 months was life as usual. Another benefit of the device would be the size of it. Since it sits just under the arm there on the rib cage, it's something that I hardly notice in my day-to-day life. The Aurora EV-ICD gives me peace of mind because in my case, it's not if there will be an event, it's more a matter of when there will be an event, and this device is there to save my life. The device is allowing me to move forward with an active lifestyle. I can't imagine not being outside, being in the outdoors, hiking, going to the mountains. Doing those things with my family brings me the greatest joy.
Since Tim's had the device, I do feel great peace of mind. We feel very confident that if he has an event, that he will be okay and that we have this support. We have a great team behind us who will help make sure that he can live a very long, happy life.
afternoon, everyone. My name is Nathan Kong. I'm one of the cardiology fellows at Beth Israel Deaconess Medical Center. I'm delighted to have the opportunity to discuss a case I had the privilege to be involved in throughout my first year of fellowship. My case talk here is entitled Pseudofontan Physiology from Venous Lead Obstruction, a case of a rare complication, permanent pacemaker leads. I have no relevant financial disclosures to report. Early during my first year of cardiology fellowship, I had the opportunity to meet Mr. P in my outpatient continuity clinic. Mr. P was a farmer, and when I first met him at the age of 54, he was 54, he was suffering from lower extremity edema and ascites. However, his medical journey began much earlier than this. At age 27, he developed Lyme disease, complicated by complete heart block. He was treated with antibiotics at the time, and unfortunately, we do not have any documentation related to whether his conduction had improved. Regardless, he received a right-sided dual-chamber permanent pacemaker. 9 years later, at age 36, his pacemaker generator was at the end of life and was explanted. Due to minimal pacing burden at that time, indicative of conduction system recovery, a new generator was not placed and the leads were capped. 7 years then go by without incident. At age 43, 16 years after receiving his pacemaker, Mr. P started noticing significant right-sided facial fullness and plethora, along with neck pressure, particularly when he exerted himself, such as throwing bales of hay and after bending down, such as tying his shoes. After imaging confirmation, he was diagnosed with SVC syndrome. Mr. P elected for a trial of anticoagulation for 6 months, and he had complete resolution of his symptoms for the next 9 years. At age 52, this is 25 years after receiving his pacemaker, Mr. P presents to a local hospital with months of abdominal distension and a 17-pound weight gain. Imaging is significant for large volume abdominal ascites, a markedly dilated azygous vein, and nodular appearing liver. A liver biopsy was performed and significant for nodular regenerative hyperplasia without evidence of cirrhosis. When I saw him in clinic 18 months later with Dr. Zimbaum, he continued to have significant bilateral lower extremity pitting edema and mild ascites. He only had occasional upper extremity symptoms, and his skin exam was unremarkable without the presence of significant superficial collaterals. After a multidisciplinary discussion, it was decided to continue with medical management at that time, given the uncertainty that lead extraction would result in symptomatic improvement. When Mr. P first presented to Beth Israel, he had symptoms that were classic for SVC syndrome, secondary to lead-related venous obstruction from his permanent pacemaker. The pathophysiology of lead-related venous obstructions was thought to be a combination of thrombosis and fibrosis, and it is likely that the mechanism of venous narrowing and obstruction differs between the acute injury during lead insertion and the chronic changes that occur over months to years with chronic indwelling leads. Multiple risk factors for the development of venous obstructions have been explored in the literature, but the most consistent findings are the presence of multiple leads, reduced left ventricular function, and prior endothelial damage. The true incidence of lead-related venous obstruction is difficult to define, as many patients are asymptomatic. However, cohort studies in patients undergoing venograms at 1 year found that up to 30% of patients had greater than 50% vessel narrowing and up to 10% had complete occlusions. The vast majority of venous obstructions occur at the level of the axillosubclavian vein or the brachiocephalic SVC junction, circled here in red. Isolated SVC obstructions circled in gold are quite rare, representing only about 1% of lead-associated venous occlusions. Initially, Mr. P presented with classic symptoms of SVC syndrome, facial swelling, head fullness with positional changes. However, the majority of individuals with cardiac devices, lead-related venous obstructions are asymptomatic and discovered incidentally, either through imaging or at the time of extraction. Where Mr. P's case becomes unusual is that after a few years, he developed liver disease, lower extremity edema, and ascites, symptoms more typically observed in right atrial pressure overload states, such as right-sided heart failure. Here's a representative cine image of his venogram. We can clearly see the right subclavian SVC filling with contrast, but an abrupt termination at the SVC right atrial junction. The green arrow here highlights the collateral flow through a markedly dilated azygous vein. Presented here is an IVC venogram. We can see that there's contrast flow through the IVC, but you can appreciate that it might be slower once it reaches the right atrium and the right ventricle. The following table here shows the pressure measurements, which confirmed elevated right atrial pressures. I'm highlighting here some representative echocardiographic images. On the left is a transthoracic echocardiogram in the apical 4-chamber view, demonstrating the right atrium, the right ventricle, the retained pacemaker lead. The tricuspid valve here appears to be relatively spared, with only mild tricuspid regurgitation and no evidence of tricuspid stenosis. You can appreciate, however, a linear echo density here, highlighted by the 2 stars. On the right is a transesophageal echocardiogram in the bicable view at 120 degrees. Again, the echo-dense lucency is seen here, filling much of the right atrium, along with the retained pacemaker lead identified. To help better understand our theory of the case, here's a series of schematic diagrams. This is an anatomy at device implant at age 25. When he first presented to Beth Israel at age 43 with SVC syndrome, he likely had obstruction at the level of the SVC near the right atrial junction. Over time, significant collaterals were created, and much of his upper extremity venous flow returned through his azygos vein, which minimized the symptoms. We then believe his obstruction worsened over the next several years to include most of the right atrium, causing both SVC and IVC inflow obstructions. This compromised his collateral flow, which is now seeing higher afterload pressures. Back to our case. Unfortunately, a few weeks after a clinic visit, Mr. P had multiple hospitalizations for recurrent chylothorax and chyloscystitis. So how do we connect our prior understanding of Mr. P's physiology with the new development of lymphatic leakage? I think looking at Mr. P's clinical case through the context of Fontan physiology may be a helpful analog. The Fontan procedure, as many of you know, is a palliative surgery in individuals with congenital heart defects. Physiologically, the bicable system is directed towards the pulmonary arteries, thereby resulting in chronically elevated cable pressures, similar to what would be observed in acquired right atrial obstruction, as in our case. Over time, these chronically elevated cable pressures lead to elevations in feeding vessels, such as the subclavian veins. Since the thoracic duct drains into the subclavian vein, higher subclavian vein pressures results in slower lymphatic drainage. This physiology leads to many of the unique complications seen in adults with prior Fontan procedures, namely hepatic dysfunction, lymphatic congestion, and thromboembolic events, many of which were symptoms observed in Mr. P's case. For Mr. P, due to recurrent hospitalizations and persistent symptoms, the decision was made to attempt percutaneous stenting as a palliative bridge to more definitive therapy. You can see on the left his pre-stent deployment venogram. On the right is a pulmogram demonstrating blood flow through the SVC to the right atrium. However, as you can appreciate, there's still diminished flow through the right atrium into the right ventricle and pulmonary artery. Unfortunately, after stenting, Mr. P does not experience any clinical improvement. Several weeks later, a decision is made to undergo definitive reconstructive surgery, which was revealing for a scarred down right atrium with a densely inherent pacemaker leads onto the tricuspid valve. He has a successful right atrial and right ventricular lead extraction, right atrial enlargement with right atrial patch, and a tricuspid valve repair. This picture is taken at the time of lead extraction, showing the significant fibrosis and scarring on the pacemaker leads themselves. Mr. P's dramatic case highlights several important key concepts. First is that venous obstructions are a common complication of pacemaker implantation, and as our case highlights, can have devastating consequences, particularly when it presents as SVC syndrome. Second, this case represents an extreme and highly unusual example of right atrial obstruction leading to chronically elevated bicable filling pressures. Finally, the physiology of right atrial obstruction often mimics that of adults who have received prior Fontan procedures, and the unique complications of hepatic dysfunction and lymphatic leakage may be observed, as seen in our case. So how did Mr. P do? Unfortunately, he had multiple hospitalizations after surgery for recurrent pericardial effusions, and repeat venogram was performed, which demonstrated patent flow through his reconstructed atrium, but with azygos vein obstruction from his SVC stent. He underwent reduced sternotomy and pericardectomy with evacuation of dense gelatinous fluid. Since then, however, he has been doing well and has not had any further hospitalizations. He attends his routine outpatient follow-ups. I want to thank the enormous number of people who took care of Mr. P, as well as helped mentor me throughout this highly unusual and rare case presentation. I would like to extend a special thanks to Dr. Peter Zimmerbaum, my clinic mentor, and Dr. Brett Carroll, a vascular medicine specialist, for their help on the case. Thank you very much for your time and attention.
That was an incredible case. We have Dr. Kong and Dr. Zimmerbaum joining us. I think we'll take about 7 minutes here to discuss, because that was just an incredible case. We also asked Dr. Schloss to join us because that was an interesting one. And I have a couple of thoughts and comments, but I want to know what Jay thought about that case, or if he has any questions.
Thanks, Rob. The first thought, which is gosh, Lyme disease, age 25, got a pacer. I think that's the first thing that we need to learn from this case, because it applies to all of us and all of our referring physicians, that we need to be extremely careful on who we put pacers in, especially young people, and especially in people who have potentially reversible causes for heart block. So I think we're going to learn a lot today, but that might be the most important lesson of all.
Of course, yeah. Absolutely.
Yeah, always a good point. And it's important that we have you guys here, because you come from Beth Israel and you maybe have more experience than anyone in terms of vein obstruction and lymphedema. I have two questions. First is for Dr. Kong. The stenting looked pretty good, but it occluded the. I would have thought it would have worked, but it occluded the azygos. Was the stent placed in the wrong place? Is that why it didn't ultimately work percutaneously?
Yeah, that's a great question. We were trying to manage him also in line with kind of his goals, which were to try things before leading to kind of the ultimate cardiac surgery. And I think what we had discovered kind of throughout the case is that the stent, the percutaneous stenting, was probably pre the ultimate occlusion, which is why it ultimately didn't totally relieve his obstruction.
Yeah. Yeah, I would exactly. I would add, look, I think every center has their own biases in this regard, and we work closely with the vascular surgeons and who at our program are very minimally invasively oriented. They do a lot of arterial stenting and reconstructions. They are extremely loath to ever use a venous stent. It's something that is Mark Schermerhorn runs that program, and I can tell you it's something we virtually never, ever do it. And similarly with our vascular interventionalists. So this was a very unusual circumstance in which we did do it because they migrate. And that was one of the first concerns, actually, is that stent had migrated. And in fact, it was where we left it. But as Jason said, I mean, the real issue, what was interesting about this case is that it began, probably the initial insult a decade earlier was the gradual development of SVC syndrome, but it really became a case of RV scarring and invagination, and that was the Fontan physiology. So it's, we managed the SVC, I think, at least as what we thought would be symptomatic relief, but we learned in the absence of a response to that this, there was a more distal obstruction. And that's probably why we saw so much of what was initially, this guy presented actually through the liver service, and then they got us involved because of the ascites. So I think that was I've never seen this in 25 years of doing this. I've never seen this degree of RA invagination. And I think that was really, that was the very unusual fundamental problem here.
I've never heard of that either, and it's kind of like the systemic version of a swollen arm. I have one more question for Peter mechanistically and for Jay clinically, which is so many patients have occlusions of their SVC, narrowing, stenosis. Frequently, you'll see patients with complete obliteration of their SVC, and you had no idea it was in there. They're completely asymptomatic. So is there a reason to think that some patients have stenosis and they have this leaky thoracic duct and they have subacute symptoms of heart failure that maybe can be improved if they're treated? Does that make sense mechanistically? And I'd like to know if Jay has any experience thinking about that over the last few decades.
Yeah, I'll say that's a novel concept. And I'm learning today along with the rest of you. I have certainly seen many people with surface collaterals, and what I always tell these patients is that the only thing that really bothers is electrophysiologists when they try to do the next implant. But I think your points are. I mean, this was an unbelievable case, and this is obviously the end stage of the worst thing we're going to see here. But I'm going to take home from this some new thoughts to be a little bit more proactive at looking for this, especially now that we have some techniques available.
Yeah. Yeah, I agree. I think, look, I think nobody understands the venous system very well. I think that it's incredibly neglected, and maybe we'll get to a place where we're thinking about venous hygiene, and that means, pretty aggressive evaluations of early obstruction and trying to do things. I'm a lot more aggressive with early anticoagulation when I see evidence of any obstruction, and I think that I'm not yet imaging the SVC, but that may be something we evolve to. I mean, we did that analysis looking at the sort of the tip of the iceberg of the frequency of this, but I think it's a pretty ubiquitous problem. If we look, we're going to see an awful lot of obstruction. And, in older patients, it's not generally an issue over the course of their lives, but I think in younger patients, it's a really big deal. And I think younger patients tend to develop a lot more fibrosis. And this guy is sort of, the setup for it, I suppose. But yeah,
Certainly makes you again pause before putting a pacer in a young patient, and
absolutely.
the consideration for leadless. I think anybody that came through this presentation is going to be a little bit more keen on leadless in young patients.
Yeah, absolutely. And I think that's right. And of course, we would have taken that device out had we seen him earlier. And, but once it's been in for a decade or two, it becomes a much bigger concern to take it out and to have a good outcome.
Yeah, that begs the question. So if you had seen this patient, say, at 10 years, and they were asymptomatic with no pacing requirements, and now they're 35, would you have proactively, let's say they had a little bit of, maybe their innominate was occluded, but they had no symptoms. Would you take it out at that point or observe?
I think, I think the problem is you take these things out, and unless you have a good solution for restoring flow, I'm not sure you've done them a lot of benefit. So now I'm hoping that with drug-eluting balloons, we're going to see. I've been pretty impressed, actually, as I think Rob was saying. Venoplasty works pretty well, and I think with drug-eluting balloons, it works better than it did in the past. So I think, we offered him extraction. We saw him at that point, actually. Nathan mentioned the time course, but it was probably 10 or 15 years post, and we offered it to him, but it was, when he heard the risks, he was not interested, and he was willing to live with it. And he responded pretty well to anticoagulation at that point. But yeah, I'm pretty quick to get leads out these days in young people if they can be removed because of the long term, what I worry about over the long term.
Well, thank you so much for that incredible case. We work with Max Itkin, who's a world-renowned lymph doctor over at CHOP, and he always tells me if they have heart failure, think about the leaky lymphatic duct. So this is a great reminder.